Good evening, doctors. My name is Rahul Desai, and on behalf of FDC and MedTalks, I hereby welcome you all to today's live module in our journey of 52 weeks with Dr. K.K. Agarwal Memorial and Enazal Zero. Dear viewers, last module we have gone through the topic mistakes in diabetics. And for today's topic, which is Jugaad in diabetes, which sounds very interesting. And this reminds us of Dr. K.K. Agarwal sir and his numerous ways which we had discussed during the sessions he had taken with us. So before I hand over this platform to Dr. Sanjay Kalra sir to take us through the topic of Jugaad in diabetes, let me have the opportunity of announcing the winners of last module. And the winners are Dr. Guru Pyala and Dr. Adinarayana Potti from Andhra Pradesh. From Chhattisgarh, we had Dr. Sri Prakash Pandey and S. Pandey. From Gujarat, we had Dr. C.F. Shah, Dr. Jitendra Kumar Shah, Dr. R.K. Bhansali. From Haryana, we have Dr. Manish Kumar Jain, Dr. I.C. Garg. From Jammu and Kashmir, we have Dr. Shahid Sofi. From Jharkhand, Dr. Gautam Datta, Dr. S.S. Rana. From Karnataka, we have Dr. K.M. Prasanna Kumar, Dr. Anupama Swamy, Dr. Ramesh Hegde, Dr. Ravindranath Katta, Dr. Kashinath Dikshit. Then we have Dr. Gangadhar from Odisha. From Punjab, we have Dr. Surinder Gupta, Dr. Namrata Puri, Dr. Sanjeev Puri. From Tamil Nadu, we have Dr. Venkatesan Natarajan. From West Bengal, we have Dr. Shantanu Kumar Bhattacharya, Dr. Sunandan Pratihar, Dr. Ashutosh Das, Dr. Dheeraj Kumar Haldar. From Delhi, we have Dr. Sumita Sharma, Dr. Ashwini Malhotra, Dr. Bimla Kambur, Dr. Umesh Kumar Malhotra, Dr. Vibha Mehta, Dr. G.S. Batra, Dr. Surendra Chadda, Dr. Vinit Kumar Ladia, Dr. Rajan Pradhan, Dr. P.C. Pahwa, Dr. Manu Sharma. From Maharashtra, we have Dr. Nitin Patil, Dr. Girish Gesota, Dr. Damodar Jeswani, Dr. Hitesh Vora, Dr. Bharat Picha, Dr. Kulbhushan Tandon, Dr. Dharmika Tandon, Dr. Harsh Shah, Dr. Aditya Mahajan, Dr. Aspi Mehta, Dr. D.G. Parmar, Dr. Shashikant Chandwadkar, Dr. Neelam Mehta, Dr. Manisha Dhinge, Dr. Farid Kimani, Dr. Rajeshwari Sunku, Dr. Utokshi Zaruliwala, Dr. Kaval Saluja, Dr. Vani Kanpati, Dr. Poonam Shahani, Dr. Meena Ajbani, Dr. Lalita Bhatt, Dr. Dakshyani Menon, Dr. Kirit Lalan, Dr. Shashikant Chende, Dr. Bhavini Gala, Dr. Hemant Adikane, Dr. Gajanan Sanab, Dr. Pratibha Angne, Dr. Pratap Parkar, Dr. Posanlal Baisen, Dr. Smriti Matre, Dr. Seema Shah, Dr. Sanjeev Desai, Dr. Jayshree Avlekar, Dr. Anand Purandre, Dr. Pramod Umarji, Dr. Anupam Agarwal, and Dr. Suman Agarwal. And from Uttar Pradesh, we have Dr. Irfanullah, Dr. Surjit Kalsi, Dr. Sanjay Mehrotra, Dr. Asma Saeed, Dr. Krishna Bahadur, Dr. Anil Upadhyay, Dr. Ashwini Kumar, Dr. Rajesh Jain, Dr. D.P. Mishra, Dr. Javed Ahmed, and Dr. Suresh Kushwaha. So congratulations to all the winners. And with this, I hand over the platform to Dr. Kalra, sir. Over to you, sir.
Thank you, Rahul, and a warm greeting to everybody who is gathered with us today. Sunday evenings are a nice time to relax, to introspect, and to see what we have done in the past 1 week. Now, I hope that my slides are visible. Rahul, can you see the Jugaad?
Yes, sir, visible.
Fine. We'll talk today about Jugaad and diabetes. Like I said, Sunday evening is a good time to introspect, to reflect, to see what we did in the OPD about the past week, whether we made any errors, whether we can improve. Now, improvement and innovation is part and parcel of human life. In India, improvement and innovation become even more difficult, more challenging because of the many resource challenges and crunches that we face. So therefore, we also have to rely on something that we call improvisation. The Hindi or the Urdu word for improvisation is Jugaad. So today, let's talk about Jugaad in diabetes. We know what the books say. What the book says is accurate, but it may not always be appropriate. And finally, the person whom we are serving is our patient, the person living with diabetes. The person living with diabetes has not read Harrison textbook or Davidson, and certainly has not read the American or the European guidelines. So therefore, sometimes we have to tweak what is written in the guidelines into what is appropriate. Later on today, I will speak about something known as logical empiricism, and I will talk about my life as a diabetes care provider, how it has changed over the past 2 decades or so. But for now, let's talk about Jugaad or improvisation in screening. Now, the definition, the book says that when you diagnose diabetes, you have to do a venous test. When you manage diabetes, when you monitor diabetes, you can do capillary testing. The question is, what do we do when we are screening for diabetes? If it is a research protocol, then certainly venous sampling should be done. But if you are doing it routinely in the OPD, then you can actually get away with capillary blood. The reason is the patient will ask you, and you will be able to say very categorically, very confidently, that the modern glucometers, the good glucometers, are now calibrated properly according to venous blood. So you don't have to increase or decrease the number. It is actually calibrated according to normal glucose values. The guideline says that you should do a post-load glucose to screen for diabetes after giving 75 grams of anhydrous glucose or 82.5 grams of the normal glucon D that you get. But in practice, I do not do that. We just ask our patients to come for a postprandial test, and we ask them to take a heavy meal, both carbohydrate and fat, so that we can screen. So you can do a fasting, you can do a postprandial, 2-hour postprandial. If you are really in a research setting, you must do post-load. And at times you can do a random glucose as well. That is called opportunistic testing. Remember that if your patient is asymptomatic, you will have to show at least 2 abnormal values to label the patient as having diabetes. If, however, your patient has symptoms suggestive of diabetes, even a single abnormal value will suffice. Once you have screened, let's move on to diagnosis, and let's look at the Jugaad here. There are 3 ways of diagnosing: fasting, post-load, and HbA1c. We already mentioned that post-load is difficult to do in routine practice, so you can do postprandial as well. HbA1c limitations are there in India. Many of our patients have anemia. If you have a high turnover anemia, like blood loss, then again the HbA1c may get altered. If you have a low turnover anemia or a hemoglobinopathy, again HbA1c may be altered. So do not rely too much upon HbA1c, especially if your patient is anemic or your patient has got a hemoglobinopathy. Hemoglobinopathies occur across the country, but the part of the country where hemoglobinopathy is most common, and therefore where HbA1c is least reliable, would be West Bengal. So just check if there is a family history of hemoglobinopathy. If you're in doubt, get an hemoglobin electrophoresis done. I myself prefer fasting and postprandial. Like I said, the book says to do a post-load, but usually I prefer fasting and 2-hour postprandial. We have talked of screening of diabetes, but gestational diabetes is a separate entity altogether. In gestational diabetes, the diagnostic criteria are different and the targets are different for treatment. We should be aware that any value above 140 is diagnostic of GDM in pregnancy. Ideally, you should do a 2-hour GTT. But DIPSI, DIPSI, this is an Indian body which has suggested a 75-gram post-load glucose test. What DIPSI says is you don't have to give this 75-gram fasting. You can give it any time of the day, whenever the patient comes to you, whether she is fasting or not. You just give 75 grams of glucose and check the glucose after 1 hour. If it is more than 140, you label the patient as having gestational diabetes. This DIPSI criterion is very good to use in India. How do I use it in my practice? The purists, the people who say that you must practice pure medicine, you must not innovate, you must not improvise, you must not do Jugaad, even though you are practicing in a small town or village of India, they say that I should do a proper GTT. So if my patient is willing to get it done, if she is from Karnal city, I do advise that. But if my patient has come from far off, she has come from 60, 70 kilometers away, she has come by Haryana Roadways bus, the roads are so bad after monsoon, then I will not trouble her. She is already in second trimester of pregnancy. So I will just make her sit for 1 hour and do the GTT. So this DIPSI method of screening for GDM, some people will call it a Jugaad, but I would call it a great innovation for India. Our targets in GDM are different. So right now we were speaking of screening, but let me take a detour. Our target in pregnancy would be a fasting of 95 or less, a 1 hour postprandial. This is one situation where we do 1 hour PP. it should be 140 or less. And if you happen to do a 2-hour PP, it should be 140 or 120 or less. I apologize for the typo. So 95, 140, and 120. These are our targets. We have used the word GDM so many times. But let's spare a thought for the lady whom we are diagnosing and for her family, her society. Now, Dr. Manish Jain and Dr. I.C. Gargar from Haryana, they won the prizes last time. They know that many of our societies are not very girl friendly, and they are not at all friendly towards a new daughter-in-law. So the daughter-in-law, she got married last year. Now she is antenatal. She is bearing the in-law's child. And the moment you diagnose diabetes or sugar, the immediate answer will be, you have got sugar from your mother's family. Why don't you go back there? You get treated there, let them spend all the money, then you come back. When you get a grandson, then you come back to us. Otherwise, you stay there only. So avoid using the word diabetes mellitus. Avoid using the word diabetes or sugar or shakkar in newly married girls who have GDM. Just look at the mother, the mother-in-law, look at the family, look at the husband. Choose your words carefully, please. This also, some people might call it a jugaad, but I would just call it sensitivity. You can use a word like dysglycemia or maybe carbohydrate intolerance. That is actually the definition of GDM. Carbohydrate intolerance of pregnancy, CIP. You can write a term like that. If the mother-in-law or the husband asks you very pointedly, you say it's not permanent diabetes, it's just carbohydrate intolerance. You just need to follow diet and exercise. Because 90% of the time, GDM will respond to diet. So that is why you can also call it nutrition responsive dysglycemia. Tell the woman, tell the family, you do not have to go hungry. Eat well, but eat 6 meals a day, 3 plus 3 meal pattern, 3 big, 3 small meals. Eat well, but do not eat simple carbohydrates. Prefer complex carbohydrates. Eat well, but do not take fat, do not take ghee, too much of cooking oil, butter, or cream. Why don't you prefer proteins? Couch your language in such a way that you say that this is beneficial for the baby. So you say, see, if you eat that carbohydrate, it may not harm you so much, but the baby will get harmed. So for the baby's sake, please take more of protein, more of complex carbs. So this is also a kind of jugaad that we do. I avoid using the label of GDM in my OPD. I go out of the way to to make the lady feel relaxed, to make her husband feel relaxed. And by default, the family atmosphere also becomes relaxed, and actually glucose becomes better. Otherwise, a stamp of GDM, especially in many North Indian states, can lead to a lot of domestic and marital discord. We're talking today about jugaad in diabetes. So let's talk about how to choose therapy. You can do a jugaad by choosing drug combinations, choose complementary classes of drugs. But remember always that safety is first, safety is paramount. Let me share this classification of non-insulin glucose-lowering drugs, an improved classification over what we have shared earlier a few weeks ago. We have insulin secretagogues, remember, glucosidal, insulin sensitizers, remember, glucostatic, calorie restriction mimetics, just like incision and drainage, and also calorie restrictors per se. When you want to do a jugaad and you want to treat therapy, you try to take one drug from secretagogue class, one from sensitizer, one from calorie restriction mimetic. What kind of a jugaad will you do? Look at the slide in front of you. If the risk of hypoglycemia is low, you can choose anything. But remember that sulfonylureas will have a higher risk of hypoglycemia. Sulfonylureas will also have a higher risk of weight gain. This is especially true for the older SUs, not so much for the modern ones. If you want to focus on CV risk reduction, then it would be best to give GLP-1RA and SGLT2 inhibitor. So the jugaad is that when you are selling this medication to your patient, you are motivating your patient to take it. You say, I'm not giving you this drug only for glucose control. It is not a treatment. It is actually a prevention. It will prevent heart disease. It will prevent kidney disease. It will prevent hospitalization for heart failure. So I am giving you this as a prevention, as an insurance. That is preventive language. Now let us use promotive language. This tablet that I am giving you, it is not a treatment for blood pressure. It is not also only a prevention of kidney disease intervention. It is actually a promotion of youth. When we give you this medicine, it will reduce the stiffness of your arteries. Your arteries are going old, yours as well as mine. All our arteries are growing old. But this particular drug, now it can be BP lowering, it can be statin, it can be glucose lowering. This will promote youth. It will promote longevity. It will prevent premature aging. So you are using a promotive language. So preventive as well as promotive language should be used, as opposed to curative language. Curative language will be, why don't you take such and such an antibiotic? This will help cure your pneumonia. This kind of a language will not work in chronic disease. You have to have promotive and preventive language. The Latin word is salutogenic. Instead of using a pathogenetic language, we should use salutogenic. Salus means health in Latin. Have you ever understood or thought why our colleagues in alternative therapy are so popular with the general public, while we are not so popular? The reason is that our alternative colleagues, they are not trained in pathogenesis, in pathology or biochemistry. So they do not know what pathogenesis and biochemistry, pathology and biochemistry is. So they just talk of wellness, they talk of well-being. And they say, I will give you this drug. It may be validated, it may not, but it is going to promote wellness. And that is why patients like it. So don't worry too much about what they do, but let us do the right thing. We will focus on CV risk reduction, on promotion of longevity, and that is how this is a kind of jugaad in convincing our patients to take the latest and the best drugs. If you want your patient to lose weight, then you will say something like, I am prescribing this GLP-1 RA. It may be expensive. I am prescribing this SGLT2 inhibitor. You have to take an extra tablet, but it will help reduce your weight, which will help reduce the need for other glucose lowering therapy. So that is the jugaad. You are using a glucose lowering therapy to promote reduction in other glucose lowering therapy, sparing of other glucose lowering therapy, and also weight loss. On the other hand, if you have a catabolic state, then the jugaad would be to use sulfonylureas or DPP-4 inhibitors and small or medium dose of metformin. This we have already discussed, and let me repeat it. This jugaad which I follow in my OPD, don't get too many tests done. But if your patient is overweight, obese, has stigmata of metabolic syndrome, then prefer SGLT2 inhibitor and GLP-1 RA over along with metformin. If your patient is predominant catabolic, thin built with symptoms, prefer insulin, or as second choice, insulin secretagogues. And if your patient is eubolic in the middle, then you can prescribe any kind of drug. One other jugaad is to minimize the pill burden. So use dual oral therapy or triple oral therapy. Another jugaad is to use scored tablets. So look at all the tablets that you get. Look at the companies that you prefer. Just look at the tablets. See what the size is. See whether they have a line in between. Are they scored? If you can use scored tablet, you can tell your patient, yes, Navratras are coming. If you keep a fast, you take half tablet. If you don't keep a fast, you take full tablet. So you are empowering your patient. In injections also the same thing is done. We will talk about that later. And another jugaad is to offer flexibility to the patient. You can take this tablet 5 minutes before a meal, immediately before a meal, immediately after, or even 5 minutes after a meal. If, however, you end up taking it 1 hour after a meal, please take a biscuit or a chapati or an idli extra. So this flexibility also helps your patient feel empowered and helps your patient feel happy with the medication you are giving. I just spoke of pill burden and I alluded to insulin burden or injection burden. Let me talk about injection burden. We have discussed this in the past. We speak of insulin regimens. First, you decide your regimen, basal or premixed or basal bolus. Then you decide the preparation, human or analog. Then you decide the concentration and then the delivery device. But patient is not bothered about all these. Patient counts only number of injections and number of devices. So let us say your patient was on maybe glargine twice a day. You just change and patient is not getting controlled. You change to premixed insulin twice a day. Number of injections will remain the same. If you are giving 2 injections a day, in the first prescription, try to give the same injection twice a day so that the patient has to buy only 1 delivery device. Don't give 3 different types of injections on day 1. Even if you want to, you can do it later on the next visit or the week after that. So here the jugaad is go slow, go soft on the patient. Use initially, minimum number of injections, minimum number of pens, so that the patient feels comfortable. My commonest prescription would be 20 units twice a day of premixed insulin analog. Now, this 20 units twice a day means 40 units per day. So the pen will last 7.5 days. So I call my patient back after 7 days. First time patient has to buy only one delivery device. Supposing glucose doesn't get controlled, next week I can give maybe 50-50 insulin in the morning to control postprandial glucose and 30-70 at night. So that is 2 delivery devices. Or I can give rapid in the morning, rapid in the afternoon, and premixed at night. 3 injections, 2 delivery devices. Or I can go up to basal bolus, 3 rapid acting and 1 long acting at night. That is 4 injections, 2 delivery devices. But in the first meeting, unless there is a life-threatening, organ-threatening, or limb-threatening situation, I will stick to 1 injection and 1 delivery device. Similarly, for monitoring, the jugaad is that you must monitor, but don't trouble the patient too much. So if your patient is not happy doing blood glucose monitoring, you can always ask for urine sugar monitoring. You can teach the patient how to do that. You must monitor for complications. But complication monitoring is also a very long and tedious process. In practice, we don't have an idea. So what I do is I take one history suggestive of macro and one history suggestive of microvascular complications. So my routine history taking style is as follows. Good morning, madam. How can we help you? For how long have you had diabetes? Since when is your glucose very high? How long do you feel, since when has it been that diabetes is troubling you, is winning the battle against you? So patient says, maybe I've had diabetes for 10 years, but for the past 4 to 6 months, I'm not doing all that well. Okay. So now I try to find the etiology of uncontrolled sugar. Any infection, any skin infection, any urine or genital infection, maybe any cough or cold, any discharge from the ear. All this is in one sentence. Then I look for complications. Any history of hypertension, high cholesterol, heart disease, maybe any sweating on exertion. For microvascular, how are your legs? I hope your legs and feet don't ache. Do they trouble you more at night? Do you pass urine okay, adequately, or do you have to get up at night? How is your eyesight? This is a routine way of asking questions. It has taken just a minute or so. Based upon what the patient says, you move ahead and you keep on probing more. One surrogate history I would like to talk about is happiness, and the other one is sexual function. So these are surrogate markers, and my OPD consultation is always begins with, so are you happy? Do you wake up happy in the morning? Do you go to bed happy at night? For sexual function, I hope you're doing fine. Of course, I'm more comfortable with men, and I personally do not go out of the way to take a history from women. I do ask for urinary infection and genital infection. But in case the lady volunteers, I am able to take a history now, and I am able to help her with basic advice. Erectile dysfunction is something that will suggest both macro and microvascular complications. Sometimes your patient may say, Daksa, why are you asking me this question? Then you say, I'm asking it as a surrogate marker. When you give me an answer that yes, you are fine, it avoids so many investigations and tests. So I'm trying to help you save time and money. Most often, the patient will come back to you after a month or 2 months and will say, Daksa, in January, you asked me this question. Now I have a problem. So then you go ahead with whatever investigations are required. You can also use questionnaires to save time. So there is a PHQ-2 questionnaire, only 2 questions. WHO 5, these are all for well-being. There are questionnaires on erectile function, questionnaires on sleep apnea, questionnaires on restless leg syndrome. Depending upon the kind of morbidity that you see in your OPD, you can get these questionnaires translated into local language. Mostly they are available on net, and you can use these. Your receptionist can also put these questions to the patients. We are speaking today about Jugaad or improvisation. The most important improvisation is, or innovation is, teamwork. So do not hesitate to refer to a colleague if you feel that things are not going smoothly. And within your OPD, let us say you do not have an educator, you do not have a nurse, use your receptionist, use your sweeper, use the ward boy, use the pharmacist. teach them one fact a day. In 1 year, they will have learned 350 facts. Tell them to share with as many patients as possible. The fact just might be, do not eat ghee. Do not put oil or ghee on your chapati. Prefer idli over dosa because idli is steamed, dosa is fried. Prefer wheat or rice with the husk as compared to maida or white rice. So these are simple things, and you should involve each and every member of your team to the best possible, in the best possible manner, in the maximum possible extent based upon their caliber. So today we have spoken about Jugaad and diabetes. Let's talk about our questions for the week, the ones we had last week. Last week was, question number 1 was, individuals with diabetes are at high risk of heart disease if they smoke. That was the answer. All the others are protective factors. The other one was, which electrolyte deficiency causes weakness, fatigue, cramping, paresthesia, paralysis, nausea, vomiting, cardiac instability, and lethargy? The answer is hypercalcemia. So that was the NRSAL 0 question for last week. Let's have our questions for this week. These are tough. Now, this measure does not help to prevent diabetes complications. Note the googly, it does not help. A, controlling lipids and blood pressure. B, prompt detection of eye and kidney disease. C, eliminating carbohydrate from the diet. And D, controlling blood glucose. So which of these does not prevent complications? Controlling lipid and BP, detecting eye and kidney disease, eliminating all carbohydrates, and controlling glucose. And the second, again, the NRSAL 0 question. Electrolyte deficiency can be caused by many reasons, but alcoholism, malnutrition, vomiting, diarrhea, hypocalcemia, and hypokalemia all are causes of which of the following? Hypermagnesemia, hypomagnesemia, hypocalcemia, hypernatremia. Let us repeat this question. If you have an alcoholic who is malnourished, who is losing body fluids through vomiting and diarrhea, who already has low calcium and low potassium, what can this lead to? High magnesium, low calcium, or high sodium? We have talked today about Jugaad. Let's see the questions and comments that we have today. Lots of questions coming in. Good evening to Ashutosh ji and Dr. Vikram Saini. Dr. Vikram says, what are the sources of rich protein diet for vegetarian patients? So the best would be dairy products, milk, curd, buttermilk, and cottage cheese. The second best would be dals and lentils. So different types of dals, chana, rajma. The second richest source of protein amongst the dals in India is soybean, white soybean. The richest source is something known as bhat ki dal. Bhat ki dal. This comes from Uttarakhand, and the English word is black soybean. This has got the highest protein content amongst all dals. So these are the two main sources of protein in our diet. We have lots of other questions. Harish, Dr. Harish saying hi and answering the question, okay, A and B. Thanks, Dr. Harish. And Dr. Arpan Agarwal says, why do doctors prescribe metformin to non-diabetic people? It is being done for anti-aging and any hormones. Okay, this is a very important question. So let's talk about aging and anti-aging. Now, metformin is actually an anti-aging drug. In many animal species, it has been found to be effective across all individuals. In human beings, there are some responders and there are some non-responders. We do not know exactly who will respond, who will not. Maybe later on a time will come when genomic studies will be done to diagnose that. But people do use it for anti-aging. In India, it is not very common, but you can try. Let me tell you the kind of patients you will try in. And the possible side effect is hypoglycemia. The glucose level will not be low, but patient will come and complain of neuroglycopenia. Patient may come and say, I'm not able to concentrate, I'm not able to study, I'm not able to read. So if there is a thing like that, you stop. Let us talk about the situations where you will prescribe metformin to a non-diabetic individual. S is for severity of glucose. If the glucose is in pre-diabetic range, you can prescribe. S is for sustained. If the glucose level is always on the higher side, of course, diabetes will be diagnosed at 126, but always the glucose is coming as 108, 1010, 109, sustained, then again we will prescribe metformin. If there are symptoms, S for symptoms, then also you can give. The symptoms may be suggestive of diabetes, like asthenia or polyuria, polydipsia. The patient may not have a label of diabetes according to the guidelines, but you can consider giving. So 3 S's. More S's are coming up. One is spectrum of metabolic dysfunction. So if your patient has got maybe a fatty liver, maybe polycystic ovary syndrome, obesity, then we will consider giving metformin. S for spectrum, S for susceptibility. Family history of diabetes, family history of premature cardiovascular disease. Again, metformin is a good drug to give. S would be for self-requirement. Patient says that he or she wants excellent glucose levels. So then again, we can go ahead and give. When you prescribe metformin off-label, do make it a point to note why you're doing that, so that if any other doctor sees the prescription, he or she should be aware. Dr. Ashutosh is taking metformin 500 milligram SR once a day. If you're comfortable, you should continue that. There's no harm in that. How is metformin anti-aging? It is a calorie restriction mimetic. So it acts upon the mitochondria. It activates an enzyme known as AMP kinase. And this is the same thing that is activated with calorie restriction. It actually improves the length of increases the length of the living being. One more question is coming from Dr. Pooja Singh. HbA1c is 6.7, taking Remo M twice a day, but fasting is not controlled, 150 to 180. PP is also not controlled, 240 to 200. Voglibose will not act, but Remo M, Daksa, we should stop. We would need your HbA1c also to be aware. Remogliflozin is not validated, is not supported by cardiovascular outcome trials. So maybe you can take a different SGLT2 inhibitor instead of Remo, maybe empagliflozin or dapagliflozin or canagliflozin. Continue metformin, and we need to add a third drug because glucose is not controlled. So we have interchanged Remo to a better SGLT2 inhibitor. We have continued metformin. You might wish to increase metformin to 850 BD. HbA1c is 6.7. I noticed that now. But to add a drug, either we will add maybe a DPP4 inhibitor like vildagliptin, 50 milligram BD. That should be safe. If it doesn't work, we can think of a sulfonylurea like glimepiride 0.5 milligram BD. And of course, the antidepressants can increase glucose. Certainly they do. So focus on your mood swings, and also add a gliptin, vildagliptin or linagliptin. If that doesn't work, then you can add glimepiride or glyclazide. Homeopathy, I doubt if it will help, sir, because honestly, I doubt. I would like to say this on this platform. The medicines that are being given for diabetes are being given on a particular pathophysiologic basis. They are being given after thinking. And mix and match is not a good idea. Certainly, mixopathy would not be a good idea. Taking homeopathy based upon a different pathology, taking modern medicine based upon a different pathology, I doubt if it would work. It might actually harm the body. We have a few more questions as well. Dr. Jitendra Kumar says, are 4 doses of insulin a must for type 1? Ideally, yes, sir. And certainly, yes. Many times, Jugaad is done. People give premixed. In short term, it may work. But when these boys and girls grow up, they come with very bad complications. And it is really, really painful. So we must advise them to take 1 basal and 3 bolus every day. In type 1 diabetes, 1 dose of Ryzodeg or 2 doses of premixed will not be justified. I do have a few patients. I know that in many government colleges this is written, but it is not justifiable. How do we initiate and maintain insulin? If your patient has come to you for the first time, if patient is in metabolic compromise, of course, patient will get admitted. If the patient is in ketoacidosis, if patient is not in acidosis, you don't need to admit. You start basal bolus. Maybe a rough starting dose would be 0.5 unit per kg per day. Divide that into equal parts. Roughly 50 to 60% will be the rapid acting, divided as 3 times, and roughly 40 to 50% will be the basal. So you begin with this and then you keep on titrating. Venous and capillary blood glucose samples are not the same. The values are not the same, but the glucometers that are available now are calibrated according to venous. So the number they will give you is the same as venous. If Dr. Gangadhar Rath says if a patient's glucose is not controlled with even 120 units of regular insulin, maybe we are not giving enough basal. We need to give a long-acting basal insulin at night. That is one. Probably there will be some undetected infection. So search for a focus of infection. It might be otitis media, might be a pneumonia or tuberculosis, might be melanocystitis or pruritus vulvae. These are the common ones. So search for a focus of infection. Search for an invasion, maybe some tumor. Search for irritation, some psychosocial cause. If you cannot find out any reason, then you look at I for injection technique. How is the patient taking injection? Ask for the pen, ask for the insulin syringe, see if they are matching. This is the commonest mistake that we see in practice. The insulin that you are writing is something else, what patient is taking is something else. Where is the patient injecting? Is the patient injecting on the abdomen? Did you teach properly? Does the patient have lipohypertrophy? Maybe patient is injecting on the lipohypertrophic site from where insulin is not getting absorbed. Then you look at the medication. Are we giving only regular? We should give basal as well. We just mentioned 40 to 50% should be basal. If even then you are not able to control, then you look at insulin sensitizers. Are we giving metformin, pioglitazone? We might wish to add SGLT2 inhibitor or GLP-1RA. So this is the way in which to go. Look for diet as well, diet and exercise. Patient might be taking a lot of ghee or butter or cream. Dr. Sandeep says, how to monitor on urine glucose. Yes, what Dr. Sandeep is saying is right. A patient on SGLT2 inhibitor cannot be monitored with urine glucose. Others can be monitored. And especially if you have elderly patients, American Diabetes Association also says you monitor with urine glucose only. So how you monitor? You have to do a double void sample. Suppose I want to check pre-lunch. So I will tell the patient you pass urine at 1 o'clock. At 1:30, again you pass urine. Let us collect the 1:30 urine, 1:30 p.m. urine. That is the fresh urine that has come from the bladder. So double void, this is pre-lunch. Then you also have to do paired glucose testing. So first was double void. Paired glucose means before lunch and 2 hours after lunch, so that we see whether the lunch dose is adequate or not. So dual void and paired. This is the way to check. But in SGLT2 inhibitor patients, it will not work. And it is especially indicated in elderly patients so that they have to prick themselves less. Pramlintide is a question asked by Dr. Kishore Jumani. This is available in USA. It is an amylin agonist. It is indicated for treatment in type 1 diabetes only, not in type 2. It is not available in the country. HOMA IR, again, a good question from Dr. Linus Rodriguez. HOMA IR is not needed in practice. It is just a research tool. Basically, it tells you whether the patient has got predominant insulin resistance or secretory defect. So instead of HOMA IR, what we will do in practice, you look for stigmata of insulin resistance, central overweight, darkening of skin, acanthosis nigricans, skin tags, associated conditions, obstructive sleep apnea, fatty liver, polycystic ovary syndrome. All these will suggest HOMA IR. This is clinical. Now, biochemistry, instead of checking a fasting insulin, which is quite expensive and which is not accurate, you can just check triglycerides. So there is something known as triglyceride glucose index. The higher the triglyceride level, it means the higher the free fatty acids. The higher the free fatty acids, it means the higher the insulin resistance. So the higher the product of triglycerides and glucose, the more the insulin resistance. This is what I do in practice. If serum triglyceride is high, that is a sign of insulin resistance for me. So I've mentioned the symptoms, the associated spectrum, comorbid conditions, and also the biochemistry. Okay, so a comment from Dr. GM. We are taking no ghee oil. That is very good. No potato and no rice. This is very good. Little bit of potato and rice you can take, provided it is boiled or steamed, not cooked with ghee or oil. And since 2005 you are doing that, तब भी कंट्रोल नहीं हो रहा, इसलिए होम्योपैथी ट्राई करेंगे. बट डॉक्टर साहब एक HbA1c तो कराए ना. अब देखो 2005 से आप इतना परहेज रख रहे हैं, यू आर वर्चुअली स्टार्विंग योरसेल्फ सिंस 2005, एंड इफ देयर इज नो कंट्रोल देन वी नीड टू गेट द टेस्ट डन. Without being rude to anybody, without any disrespect, if there is a school of medicine that has not been able to measure glucose for the last 200 or 2000 years, they have not been able to measure glucose, they have not been able to create a glucometer, I cannot understand what they are going to treat. When you check temperature, you use a thermometer. When you check glucose, you use a glucometer. Now, if the exam is going to be set by the glucometer, the medication should also be concordant with the glucometer. This is all I would have to say. If there is anybody, any businessman who says that he has claimed to natural cure of everything, then he should be able to measure the diseases as well. He should be able to measure thyroid. He should be able to measure glucose. He should be able to measure blood pressure. For all these things, we depend upon allopathy, how to measure blood pressure, glucose, cholesterol. And then when it comes to criticizing, then again, we choose allopathy to criticize. Maximum dose of metformin for a 42-year-old male would be 2500 to 3000 grams, milligrams, 2.5 to 3 grams. But the extra benefit of increasing the dose is not too much over 1.5 grams. So ideally stop at 1.5. Pooja Singh has panic attack because of fear of death. Even I have sometimes. Don't worry too much. And antidepressant alone is not going to increase glucose. Just take the right medication for cholesterol and BP, and don't worry, things will be fine. Gabapen 400 NT is a very safe drug to use, and Dr. Arpan Agarwal's father is taking it. It is a very good drug for neuropathy. You can continue. If diabetes is under good control, then look for other causes of neuropathy. This is a question from Nitin Narula. The common reasons would be vitamin D deficiency, vitamin D, and vitamin B12. These are the commonest reasons for pain in the legs. Others would be calcium deficiency. Of course, it can be diabetic neuropathy, but that we will consider only if the glucose levels are very high. So we've had lots of questions today, lot of comments, and let me take just one last question from Dr. Malathi Ramesh. The annual investigations for microvascular disease. Good history taking for neuropathy, a fundus examination for retina, and a urine microalbumin, a urine routine, urine microalbumin, and EGFR for kidney. So in all our patients, we do get serum creatinine and EGFR done. We do get urine microalbumin done. Before doing a urine microalbumin, rule out UTI. And we advise all the patients to go for fundus examination. For neuropathy, I rely on history taking. That was a very great question from Dr. Malathi Ramesh, something nice to end today's webinar with. Next week, I'll be back with an even more exciting and more interesting topic, and that is diabetes formula. What are the kind of formulae that we use to make our practice simple? So we'll talk about simple formulae that I use, especially with regards to non-pharmacological therapy. It's been great being with you tonight. Let's cheer for all our boys and girls, all the athletes who made us so proud at the Tokyo Paralympics. Let's cheer for them. Jai Hind.
Sir, good evening, and good evening, viewers. I'm very happy to see that almost 10 to 15 minutes Dr. Kalra has taken your personal as well as your clinical questions. That gives a pleasure to us that, when we started this journey with the objective bringing diabetes care from, from the top of the pyramid of Dr. Sanjay Kalra to your clinic and eventually to the last person who's having the diabetes. So that is serving the purpose Second thing is that to keep the excitement going on under the guidance of Dr. Sanjay Kalra, we will be definitely announcing next week something big happening which has never happened to all the doctors. I take that excitement to the next level when next week, Dr. Sanjay Kalra will announce that what we are going to do on 14th of November. So keeping that anxiety or secrets on, I take the leave for the day and wishing you all good night and maybe Jai Hind, sir.
Jai Hind.